I would like to introduce our keynote speaker. I am very, very excited to have him here with us today. That's Dr. Myles Leslie. He is a healthcare sociologist, institutional ethnographer, and an assistant professor at Cummings School of Medicine at the University of Calgary. His research focuses on understanding and optimizing communications and the culture as it influences quality improvement and safety in order to develop culturally relevant, contextually anchored quality improvement interventions. That statement right there is why I felt that he needed to be our keynote, because it really sets the tone for addressing that missing element that we often have in quality improvements programs. He's most recently, most directly, he has addressed issues through patient engagement, elder care, and trust in government. And prior to Calgary, he was appointed at Johns Hopkins Medical School as an implementation and safety researcher and the Armstrong Institute for Patient Safety and Quality. Where is Myles? There you are. So help me. Thank you, Myles, for coming.
Thanks so much for the introduction, Christine, for the invitation. And thank all you for the opportunity to kick off your conference. Like the sign says, I have no conflicts to disclose, but I am excited to be here. Here with the people of infection prevention and control. Here at the leading edge of safety and quality. And this is the beach where it all started, right? You are the people who assembled the first bits of spruce wood and canvas of the modern safety and quality movement. I realize you all get this already, you all know it already, but it's a good story. Indulge me for a moment just to be able to retell it a little bit. Those of us outside of IPC are all under the impression that these two books unleashed everything, right? This is where safety and quality comes from, we say. They're important books, and they do focus attention, but recall the first was published in 1999. Lots going on in 99, of course. Maybe it was a little bit less showy, but there was already a great deal going on in IPC too. So much going on that just 2 years later, 2 years after the book that supposedly kicked everything off, right? That's not enough lead time at all. This was already happening. The first ARC evidence report noted that 4 of the 11 safety practices with the strongest supporting evidence, the things that actually made a demonstrable difference, were related to IPC. So from working on the beaches and in the bicycle repair shops of 1999 and partying our way into the new millennium, we've moved from designing and flying one of these to, in less than 20 years, flying one of these. And it all makes perfect sense, right? The avionics meshes really nicely with the fuel management system, which does really well with the air handling system, which does good stuff with the water system inside and then the wastewater in the plane. It all works really well. You're with me on the metaphor, right? They all communicate seamlessly with one another, and it all goes like, I'm going to drop a metaphor here, I'm sorry, electronic clockwork all the time, right? So maybe there's an occasional hiccup along the way. But for me, at least, this techno-marvelous 787 cockpit calls out some interesting parallels in the audacious conference that you're attending. Really? Audacious? No. You've got audacity, a willingness to take a bold risk. You've got a 787 cockpit, and you've got infection prevention and control, the quality and safety pioneers. Who, other than a keynote speaker, would try to link all those together, or at least put them up on a slide? The first bit, the audacious bit, is that you're taking on something big, really big, professional sumo wrestler big, designing powered flight from the ground up big. The second bit is that the big thing that you've chosen to take on, the big, complicated, and socially complex thing, the whole system of infection transmissions. That's a big deal. The conference organizers and you are to be congratulated for thinking of IPC as a system. Sure, yep. James Reason and his diabolical Swiss cheese and the human factors engineers have helped along the way. The Lean Sigma folks and the design thinkers, they've helped too. Maybe they've all helped so much that it seems commonplace to talk about systems. Commonplace to a point where you're thinking, well, system thinking, that's just a buzzword, isn't it? I don't think so. What you do today and tomorrow, how you think about systems and how you go about changing them to decrease the chances that an infection moves through not a piece of cheese, but your facilities. That's beyond buzzword. Standing up here feeding you cheap metaphors about how the systems of IPC in your daily work lives are just like pieces of cheese or airline flight systems, that's playing with a buzzword. Metaphors can be helpful, and like any good speaker, I'm going to use a couple of them today. But we're none of us in the business of making cheese or running an airline, and maybe that's a good thing. We've got our own complicated and complex systems. It's not that there isn't value in making comparisons to a different set of mechanical, electronic, and service challenges, but it's pretty easy to get caught up in snappy pictures and technical understandings of systems. The audacity of this conference is that you're taking on systems in a way that goes beyond the merely complicated interactions of machinery, electronics, and people. My aim in the next half hour or so is to talk about systems in a way that encourages you to think about them and how to change them from an alternative vantage point. So what does an alternative discussion of systems look like? Well, it's not just about alternative facts, just alternative perspectives. It's not all about airline safety and the victories of human factors engineers. It's not a recapitulation of an RCA process that nicely lays out the various systems which might be at the bottom of a production defect in a widget factory. It's not an encouragement to greater depths of investigation and analysis while using methods like Lean Sigma or the quality improvement flywheel that could, the PDSA cycle. All of these views of systems have their place and value when it comes to thinking about the transmission of infections across a facility. But for today, I want to focus on the intangible stuff, the really difficult stuff that sits just outside these methods and ways of thinking about systems. How do we know it's difficult? We give it goofy, slippery names. Special sauce for the foodies. Pixie dust for the romantics. Lightning in a bottle for the more alcoholically oriented foodies. The systems I'm interested in this special the system thinking I'm interested in is the special sauce you pour over an RCA so that people actually change their behavior. It's the pixie dust that takes an A4 improvement exercise and sees the streamlined processes taken up by an entire department. It's the lightning in a bottle that strikes the systems of a whole hospital in a way that the quality improvement flywheel, that little engine that could and just keeps on cycling, actually comes to a stop. It doesn't need to keep spinning because the system is more or less doing what it's supposed to. I know that's quality improvement heresy. Somebody may let the lightning out of the bottle and have it touch down right here. It's supposed to be continuous, constantly iterating, the little engine that could, chugging along all the time and becoming part of everyday life inside the system. Continuous quality improvement. There's definitely something to that journey towards the horizon, but the alternative view of systems that I'd like to plant in your minds might not need this permanent machine. Stick with me. You'll have to accept a little bit of heresy alongside your special sauce, pixie dust, or bottled lightning. It's not just me that says you need the heresy either. I have a fellow and far smarter heretic standing with me. This man's name is Jerome. Yeah. My wife is a Dutch speaker, so she says it's Lees. And I think maybe I'll go with that because otherwise we end up at lice, and that doesn't sound very nice. I don't know Jerome's last name. I'm sorry, Jerome. He's smarter than me, and he has a name that I can't say. Jerome recently published a brilliant viewpoint piece in BMJ Quality and Safety. In that viewpoint, he raises the great boogeyman of continuous improvement cycles. How sustainable are they? It takes time and energy to keep the little engine that could running. Is it sustainable in the long run? The answer may be yes. We do need to pay for and keep running and iterating certain IPC programs. But maybe there are some where we can change the system, if not permanently, for what's permanent in life, right? At least towards a new, better normal. The problem, Lace says, is that many IPC interventions do not lead to durable practice change because the underlying system drivers remain. System drivers, for Lace and for me, are the baked-in assumptions, the shorthand about what is possible and who's capable of doing it, and how things ought to flow. This is the hard stuff. Hard because it's so soft and evasive. How do we know it's hard? Because we give it goofy, slippery names: special sauce, pixie dust, bottle lightning, and culture. This is the culture, the system that's immune, maybe even multi-resistant, to so many of our efforts. It often seems to be immune to education, like this study of anesthesiologists whose cultural understanding, their system drivers, if you will, saw them no more likely to speak up about risky operating room behavior. Doing bad stuff in an operating room, they weren't going to talk about it after they'd been told, it's really important that you talk about this stuff. Their cultural sense of how things ought to flow and what's possible and who's capable of doing it, that sense was stronger than the education they received on the importance of speaking up to address safety issues. And so it is with hand hygiene, no? The culture seems to require huge, ongoing, iterative efforts just to bend it for a moment. You let off the gas for a second, you stop surveillance or feedback, compliance drops. For my fellow heretic, Lace, the problem is that the focus of IPC work is on educating and supporting existing practices. The real objective for him, the sustainable objective, according to him, should be a complete rebuild of the system. But, he writes, rebuilding is much harder than adding supporting structures to our usual practices. Yep, culture change's hard. Tell us something we didn't already know. Everybody, not just the Harvard Business Review, everybody knows that the idea is to create an environment that supports perspective sharing and effective communication among team members who can then voice their opinions outside of silos, hierarchy, and blame. Yeah. That's the promised land of cultural change. But how do you get there? This heretic tends to leave hierarchy and blame alone. I tend to say hierarchies exist. We can push against them, sometimes successfully. But you can't, in a cliched world, fight City Hall. I also tend to say that blame is one of those things that people do that's really hard to avoid. Hence the shift over the course of the quality improvement revolution from what started out as a no-blame culture to a just culture. Look at that. Blame leaked right back in. We get to be just about this, because justice is about assigning blame. So if we need to leave hierarchy and blame alone, I really do think we could do something about those silos. And of course, I'm not alone here. The former CEO of GE is famous for taking a sledgehammer to the silos inside his organization. I'm in for the bit where silos are a point of action, certainly a better point of action than deep culture traits like hierarchy or blame. But I'm not so much about the sledgehammer and Jack Welch's efforts to break down silos. Silos are where it's at, but I think we need, regardless of what the Harvard Business Review says, an alternative perspective on how to deal with them. So let's just talk a little bit about them. I apologize again, this is probably a bit too remedial for everybody, but stick with me again. What are they good at, apart from storing corn? They support specialization, right? This is really helpful in a world of highly specialized knowledge and work, like in a medical facility. How? Well, there's probably a bunch of ways you could cut up this pie. But let's say silos support specialized work and knowledge by first improving the efficiency of work. This is about rapid communication, shorthand and jargon, the nods, winks, sighs, and turns of phrase that people inside the silo can take for granted. These are the shortcuts that allow silo dwellers to skip to the point and move to the work at hand faster. That's helpful. They provide a sense of identity and agency. Individual silo dwellers don't just acquire a set of specialty skills, they also acquire a sense of identity that is linked to their skills and how those skills make them powerful, what us sociologists like to call agentic. Why we do that, I'm not really sure. That's helpful for feeling good about yourself and the work that you do. And finally, they provide a predictable, comfortable work environment. This is a bit of an extension of the first two. The silo is a place of comfort because you know how to speak the language and read the signs. It's comfortable to work there because you can reliably predict what people are going to do because you know who they are and what their work skills and identity are built on. Helpful again for getting through your day in low rather than high stress mode. So these comfortable language and identity silos, what's the downside? There's more, I suppose, but for me and I think today, the real problem is external communication. The jargon and shorthand, all those sighs and nods that work on the inside, they don't play very well on the outside, do they? They make outsiders look stupid to insiders because the outsiders who don't get the signals, they gotta be idiots. And they make insiders look stuck up to outsiders because only snobby, non-inclusive types would be so busy with their mysterious ways of talking and being and doing in the world. If they're actually going to talk to one another, both the silo dwellers and the outsiders need to put up with and get past these feelings of you're an idiot, no, you're stupid. What I'm getting at here is that the silo, all that shorthand and identity and comfort, is doing a lot of thinking for people. And so to actually talk to one another, both the insiders and the outsiders will have to drop out of fast silo thinking into slow thinking. Sounds easy. But the catch is that fast thinking and efficient work are what people and production-oriented institutions like. Slow thinking, the hard deliberative stuff where you examine your sense that so-and-so is an idiot and such is a snob, who's got time for that? How about at the end of a long deadline-driven day? Ready for a nice big glass of slow thinking? No? I think this is the story behind hand hygiene backsliding. Our IPC efforts stand outside the various language and skill and identity silos of the hospital, literally at audit time, outside with a clipboard. As long as we actually stand there with multi-step programs that mobilize and show leadership, establish accountability mechanisms and consequences, measure and feedback the data, communicate constantly. When I say constantly, I mean constantly. And of course, ensure that there's lots of hand gel available. We have a pretty good chance of success, right? But what happens as soon as we step away, as soon as we stop, to put Lace's phrase, supporting normal practices, the fast siloed thinking kicks in. We've supported normal practices, but we haven't addressed the system drivers. We haven't rebuilt the silos, we've just propped them up. There we go. On the one hand, I guess we could spend time with these supports for normal practices. We could figure out what certain groups, certain silos value in a communication campaign or feedback chart. We could make sure that we tailor our message. I see this as the response I've often heard to recalcitrant EVS workers. We just need to find a way to reach them. We need to present our findings in a way that touches down with them. This leads to ever snappier charts and graphs, but the fast thinking of the silo's animosities, its resentments, its hierarchies, its advantages, its disadvantages, its collective sense of what the rules are and how those rules can be bent, all those mean that we're going to need to be there, not just with snappy charts, but maybe with clipboards or mystery shoppers or cameras. And so we're right back to the sustainability problem. We're committing to an expensive surveillance operation. How many electronic or actual policemen do we need standing over how many actual shoulders to make it actually work? And we're still standing outside the silo, supporting existing practice rather than inside it, encouraging a rebuilding or something else that favors IPC concerns. So how do you rebuild a silo? I guess you, as an IPC professional, could spend a lot of time getting inside it, becoming an EVS worker or a doctor or an occupational therapist or a member of the kitchen staff. But that sounds like it's got its own sustainability issues. Sounds like a project for a quality improvement ethnographer. People like me that like getting into the weird little worlds of silos and villages and hospitals. We particularly like trying to maintain the alternative perspective of a newly arrived outsider. We use this brief window of being and seeing things new to try to figure out what the local rules are and how and when people bend them. How do we ethnographers go about this? We spend time getting inside the silo. We spend time getting the insiders to put their guard down. Then, just at the point where we're becoming insiders, we either try to pull out and write up our stories, or we try to get the silo dwellers to listen to a different version of the rules and how they can be bent. I would love to say you should all hire one of me. I have business cards with me. We're cheap-ish. But we're back to sustainability, aren't we? And trying to take on this sort of work when you're also a full-time IPC professional, I'm not so sure you'll have the time or the outsider status, because that's really important. This is your hospital. This is your facility, right? How are you going to be an outsider and try to get that angle that's different? I'm not sure. So if rebuilding from the inside with a quality improvement ethnographer isn't the solution, maybe we should head back to Jack Welch and the idea of breaking down rather than trying to work from the ground up. Well, I'll let my thoughts on this come to you through the picture. What happens to all the good stuff inside the silo when you take a hammer to it and force everyone to talk to one another? I'll come back to this later. For the time being, let's set aside rebuilding and breaking down in favor of connecting. Sounds easy. And it would be if the silos weren't so good at, in fast thinking mode, not talking to one another, mistrusting one another, creating rule and rule bending systems that are completely incompatible with one another. It's a wicked problem, but let's assume, even if it is wicked, even if it will be hard, that connecting is the way to go. How do we do it? Well, at the risk of making you choke on your coffee, together. Really? Together. Kumbaya, the whole hippie thing. Yes? But let me get there a little bit slower. Consider Cincinnati Children's Hospital. This is their experience implementing an off-the-shelf IPC program way back in 2009. Remember? Everybody's house was worth less, suddenly. The hospital put in a standard perioperative bundle to reduce their neurosurgical infection rate. Nothing happened. All the usual evidence-based goodness, and nothing happened. Chlorhexidine bathing, core element of the bundle, was highly inconsistent, and audits showed that compliance with the full bundle was hovering in the mid-50s. Half the time, pediatric neurosurgery patients were receiving the bundle. Half the time. Sound familiar? Possible in your universe? How did they go about connecting the silos in the neurosurgery department? Well, they convened a multidisciplinary team to find ways to better standardize the evidence-based practices and identified simple changes to work processes like assigning specific tasks to different stakeholders. This is simultaneously a fabulous sentence and completely enraging. Fabulous because it lights the way to kumbaya, multidisciplinary, different stakeholders. Imagine putting everyone in a room together to talk about how work gets done. That's what Cincinnati Children's did. But what happened in the room? This is the maddening bit. A few simple changes? Simple? What happened in there? Just ecstatic dancing, peace, love, happiness? Simple to write a sentence in a journal article, but probably not so simple in practice. Probably a crazy amount of time spent waiting just to get the meeting together and getting the players to care enough to show up. This, incidentally, is the traffic jam to get into Woodstock, to get to all the kumbaya. Can't you just picture the pediatric neurosurgeons and the OR nurses and the OR assistants and the anesthesiologists and the EVS workers all sitting around the table for the first time after 9 months of the bundle doing nothing? Maybe it was all naked happy dancing. Maybe. Or maybe it was a bit of a mud pit. Whatever it wasn't simple. And the process changes, which just flow by in the journal article that made everyone think slowly, they dropped them out of their siloed fast thinking. The simple process changes emerged out of, I'm going to bet, just a tiny bit of political negotiation as the new rules and how to bend them were established. That's when the silos got connected. And the great news is, it worked. 2 years later, everybody's house was worth more. That may not have had anything to do with it. 2 years later, compliance with the bundle was at 86%, and the infection rates were down. So what made it work? It wasn't throwing the word multidisciplinary at the problem, although that was probably a good start. The trick here is to avoid putting the usual suspects in a room together. The multidisciplinary meetings I've attended in hospitals tend to be places outside of the usual work. Everyone lined up, not quite like these guys against the wall, but along a table, picture if you will, along a table in a meeting room off of one of the wards that smells vaguely of pizza boxes from what they brought in over the weekend. You know where we are now? Yeah? The work, the patients, they get talked about as abstractions. Under these circumstances, the usual suspects end up acting as what I would call an emissary for their silo. They have the usual siloed and silo-respecting conversations. This is the usual practice carried out in an alternative location. The same fast thinking, the same rules, and how to bend them. And I think this is the limitation of Jack Welch's approach to sledgehammering silos down by creating multidisciplinary meetings. I guess you could say it creates a boundaryless organization, but really doesn't everyone just fall into their normal patterns in a new location? So how do you get the room slow thinking rather than just importing and repeating the usual fast thinking in a new space? How do you move from the usual practice supporting fast thinking meeting to a slow thinking silo connecting mud fight? Having an urgent project like a failing bundle, that seems to work. But what happens when you don't have something nice and specific? What happens when the project is a big, powerful, but vague one, like IPC system redesign? I don't have a lot of confidence that putting everyone in the room with something big but vague, like IPC system redesign, is going to get us where we want to go. There is a book for this. A book for starting a silo-connecting, naked dancing, kumbaya mud fight. For those of you who were gutted, and I'm sure there were many of you out there, when I said ethnography wasn't really the right tool earlier, well, here it comes roaring back. But it's not a year-long ethnography undertaken by a nosy Parker like me with all sorts of fancy ideas. It's visual ethnography harnessed to quality improvement. This kind of ethnography has the worst possible name for this crowd. It's called VRE. No, not that kind of VRE. That kind of VRE. Video reflexive ethnography. It specializes at provoking just the right kind of silo-connecting mud fight. The video part sees an ethnographer, maybe even one with fancy ideas, shooting tape of everyday work. This isn't an audit. This isn't an exercise in gotcha. This is an important point I've learned in talking to clinicians over the years. Because clinicians tend to see themselves when they're being filmed as being tested, and that there will be some sort of shaming, quickening exercise afterwards where a senior clinician will, in front of a bunch of other junior clinicians, point out, you probably shouldn't have done that. I guess you could use VRE like this, but you'd be missing the point by focusing on an individual's behavior. This is about groups, whole silos. This is gathering images of tasks and groups of people doing them, not individuals, groups, systems of people. The reflexive part sees the group, all of its siloed members, brought together. They're shown a highlight reel, chosen by the video ethnographer for its likelihood to elicit comment and conversation. The group watches the tape. They have the, ooh, look, it's me moment. And then after they get past that, they see themselves in action as a group. This gently shifts them out of fast into slow thinking because they've never seen themselves working together. They've never had this perspective. And when they do, they drop out of being in work mode and into being reflexive about work mode. Sorry for the Canadian outs. An alternative perspective on the everyday makes the difference between being in and being reflexive about work. A difference between everyone showing up as a fast-thinking emissary for their silo and everyone showing up as a slow-thinking silo connector. This is the ethnography bit. Ethnography is, as I said, first and foremost about walking the line between being an outsider and an insider, on having an alternative perspective on the everyday. In VRE, the ethnographer shoots the tape, literally from an outsider's perspective, stands outside a group of people doing what they normally do, then facilitates a conversation, setting the ground rules in a way that hopefully turns out to be somewhere between ecstatic naked dancing and a mud fight. In any case, it leads to slow thinking and new rules and new ways to bend the rules. VRE's magic, its special sauce, pixie dust, bottled lightning, is the slow thinking and slow conversations. The video footage is only a means to an end. It's not the thing that does the silo connecting. The people do the hard thinking and the work that looks so simple when you write it up in a journal. Let's see it in action. We're in the Netherlands. A surgical suite sends its patients to a perioperative area where they are monitored prior to moving on to an ICU. What do we know about these transit points and borders, places like a recovery area that aren't an OR and aren't an ICU, places where teams hand off to one another? They're rife with communication errors, no? So, VRE team went in, shot tape of the handoffs, the team cut the tape down to highlight some of the things for discussion and convened everybody. Surgeons, nurses, OR techs, EVS, all sitting in a room. Then, they didn't just show the group themselves in action. They filmed them watching themselves in action. Real Hall of Mirrors kind of stuff. If you watch the footage of them doing their everyday work, what you'll see is them having very important conversations about status of the patient at the same time that they're hooking up and unhooking lines. If you then take one step back in the Hall of Mirrors and you watch them watching the footage of themselves, there's a moment where a nurse gasps, "Oh, God, no!" At another, a surgeon and an OR tech exchange glances like this. People actually hit themselves in the forehead. They cannot believe this is what normal practice looks like. We can't be acting like this, can we? They ask one another. The session then turns really rapidly to solving the problems that none of them saw until they saw it on slow thinking time, together time. The solution, after they've dropped some time talking about the whys and hows, is to develop dedicated time where certain technical things happen, and other dedicated time where information exchange happens. Simple, obvious. Well, only when you can see it for yourself. And only sustainable when you generate the fix. Because otherwise it's just somebody coming in telling you what you got to do. And we know that that doesn't work. We've talked a lot about slow thinking as the only way to gain perspective on a silo and start connecting it with another one. What are the three take-homes for connecting silos? Not unbuilding them, not smashing them apart, but getting them to connect sustainably. Time, content, and mess. All three of these are necessary, but not sufficient to proceed and succeed at changing the system drivers of IPC practice. This type of system adjustment needs time. Dedicated time, expensive, hard to find time. The kind of time EVS workers, clinicians, and administrators will say they do not have. Remember, that's not just what everyone says. I don't have time. It's also an implicit statement that they don't have time for anyone outside their silo. We could blame them for this, call them closed-minded and protectionist, or worse, and maybe we'd be a bit right. But it's also at least partly true that work and life inside healthcare has become incredibly complex in the last 20 years. The way things have evolved, it sort of makes sense to retreat into your silo, where there are solid boundaries and rules and ways of bending the rules. It's a shelter from the storm of data and demands out there. Aside from having some empathy with our silo dwellers, this reminds us about the importance of carving out time for conversation and self-reflection. Yes, it will be hard to find, but it is only with adequate time and fast thinking, that fast thinking can become the slow thinking and mutual reflection that produce simple solutions to IPC system challenges. You cannot convene a meeting, ask people for their time without content. A full box, a real project to focus the slow thinking on might be a failing IPC bundle, a Sentinel event. And if you've not got one of those, great. I mean, great that you don't have one. Unfortunate because it's been shown all over the literature that QI disasters like Sentinel events are huge galvanizing moments for organizations. All sorts of inertia can suddenly be overcome when you rally around this one point. But what if you're short a Sentinel event or worse? The less dramatic path, the more mundane, is to get an alternative view of the everyday. VRE footage is super compelling, but the video isn't the hook. The immediacy and strange familiarity of the video is the hook. This is the silo dweller's work world, but from another angle. Combine this with judicious editing and good facilitation skills, and you've got what you need to fill the time that you've carved out. Many people have a romantic idea of communities, and I'm really playing to this here. This image is of a tomato festival in a Spanish village. It has a sort of all-male playfulness to it, doesn't it? Huh? Cutesy, fruity, ain't that sweet moment in a sun-filled hilltop mercado. There's a similar romanticism to this, much-mentioned village as well. All those helping and guiding hands to raise a child, a rainbow of inclusivity and assistance. Most of the villages I know, both on stage and from my life as a healthcare ethnographer, have some significant exclusion mechanisms as well. They can be hostile and they can be petty. We live together and we work together and we disagree about the rules. And we disagree about how they can be bent. We disagree about who gets more and who gets less of the benefits, and who gets more and less of the blame. We also get along, of course, and laugh together. And between the laughter and the accusations, things get muddy. What can I tell you? Embrace the mess. Slow, messy thinking is, I'll argue, the only way to see things anew. To connect silos and so rebuild rather than merely support existing IPC structures. Margaret Mead is famous for this line. It's been turned into anodyne posters that people put up all over the place. And I suppose you could accuse her of romanticism too. And you'd be right if the small group of silo dwellers didn't have much time and only the vaguest of content to examine and renegotiate their mess. But if the members of the IPC system in your facility are given time to think slowly, to be thoughtful, and content that has them see themselves, their work, and their relationships through a new lens, if they have all that, well, they might just become a force for sustainable change. They might just connect their silos to be an inclusive rather than a divided village. A village that can find the simple solutions on its own. Thanks for your time.
Okay, we will have about a 10-minute Q&A section, so we have microphones circulating around. So if you have a question you'd like to give or a comment, please raise your hand and we'll get you a microphone.
It was an excellent talk, thank you. So in your experience, how important or what is the role of because you hear about the top-down support, right? The top-down leadership. And then, there's also that bottom-up, acceptance of how they might be moving forward. So do you have any comment, excuse me, on the role of that and how is that part of that focus? Or I'm sure you have a few comments.
When the NHS decided that they were going to force every hospital in the United Kingdom to put in matching Michigan, it was a top-down decision. It was a top-down decision, and they can work, and they can have effect. but it was a top-down decision done just after the targets and terror era, where the whole interior of the NHS had been pretty much crumbled by them introducing more and more and more and more benchmarks and then publicly shaming organizations. So when a new top-down thing came in, which might have succeeded, they didn't understand that they were putting it right on the back of something else that everybody hated, and that was the end of it. So it's not really a point of you can't do it top-down. No, there's a place for that too. I think the talk is focusing mostly on the grassroots bottom-up stuff. When I made my point at the end about don't romanticize a community, don't figure they're going to do this on their own and be nice to one another, because they're not. Part of the top-down process here is exactly the same as we were talking about with the hand hygiene campaigns. Leadership has to signal that this is important. Part of finding that expensive, nobody wants to give it to you time is leadership is saying, you're going to be part of this because we think this is the right way to go, and we're going to respect what comes out of it. The solutions that you guys generate out of your little sessions where you're talking with one another and connecting your silos, we're in. We're not going to tell you how to do this. We're going to give you the space to do this. And you, as small groups, will come up with it. So it's a mix of both at the end of the day, top down and bottom up.
Hi, good morning. Excellent presentation, by the way. So you mentioned during your VRE section about following the staff. How did you make yourself invisible so that the staff can be themselves and not project something that is supposed to be a best practice and be able to identify what the root causes of all the issues that have been identified?
Excellent. So there's I would put this in the category of the Hawthorne effect problem, right? And ethnography gets fairly regularly and roundly criticized for this. They were just doing that for you. And I have my get out of jail free card when it's a full ethnography because I did it for a year. And I can tell you, not because I have any data for this or that I can put a study up that says it, but I can tell you after you showed up for shift change at 6 a.m. in the morning along with everybody else for an entire year, nobody's given you the party line. They put the party line together and then tell you when they know that leadership is coming to the ward so that you'll be part of giving the party line when leadership comes, right? You're in. I made the point about rebuilding a silo when the foundation picture was there. An ethnographer spends an awful lot of time getting in, getting people to trust them, and then letting their guard down. And the guard is that. The guard isn't just like, oh, you're going to get me and you're going to report me. That maybe that's the first level of guard, but the next level of guard is, okay, I got to do this like I'm being watched by a policeman. And then you just sort of fade into the background. How do you do that with a camera? Well, the people who are good at this, and I would not pretend to be in any way, the people who are good at this take a month and a half off the top. First, it's just the human being that's going to have the camera. Then it's the human being with the camera. Then the camera's actually live. And everybody just gets used to the idea that, oh, it's Myles, and I don't know, he's harmless because he does this thing with a camera. I don't know. It's fine. In the end, and it actually goes like that. One of the first rules of ethnography is that within, for me, my number is 2 days, but often it's much shorter than that. You'll be being given a tour of whatever place it is that whatever silo you're entering, whatever village it is that you're coming to. And they will start to wander you around the village. And then about halfway through the tour, they will look and they will say, it's actually very, very unusual that this is happening today. This normally doesn't happen. And then they'll stop again. This is totally not what we do, but, well, he's actually appointed for this, but is doing that just for now, just temporarily. Because they're having the moment that you're talking about, which is like, oh, I have a mental image in my head of how the village works and what the organigram says and how everybody, but actually it's not what we do. And I'm constantly bridging that cognitive disjunct of what I say I do and what actually happens, except now you're here and you're forcing me to look at it. That moment where people are telling me in a traditional ethnography, it's very unusual that we're doing this today. Well, actually, you're constantly doing that, but okay. That's what you're trying to get out in the VRE session, is have them kind of go, oh, I was going to show you is that how we do that? Wow, that's crazy. Couldn't we hook the lines up and then talk to one another? So I guess it's not really an answer, but it's a process. It takes some time, a lot less time than having a guy like me show up and do it for a year. But you do have to commit to being in there. And the camera, in a former life, a long, long time ago, I was a journalist. And the first day of broadcast journalism, the guy told us in the course, when you sit down to do an interview with somebody, acknowledge and speak to the camera. So if it's mounted here, wow, this is the weirdest thing ever. This is totally going to distort our conversation, isn't it? This horrible black eye sitting here is going to kill all sense of naturalness between us, isn't it? So anyways, moving forward like that, and they will drop off of it and come to you and talk. Little techniques like that along the way, they just work. So there's a way to do this. It does take time, and you have to kind of know the bits and pieces, but...
Dr. Leslie, great session. Curious whether you've looked at the use of qualitative research, how that connects with VRE in particular, but it's a different way of addressing attitudes and beliefs and perceptions of people in the care environment, and just wonder if you looked at that at all.
Yeah. So question is, how has qualitative research been deployed to help? Or, right, I think hopefully the talk shows you that there's work being done in qualitative research that's very, very focused on intervention and change. A completely legitimate criticism of what we do generally is we come along, we come into your village, we write it up, and we say, here's what we saw, and we walk away. That's not particularly helpful, is it? Trying to find research that does more than that is sometimes difficult, but I think people sell it short as well, in that what a set of qualitative observations and interviews can give you is a theoretical framework, which everybody immediately goes, oh my God, what's he talking about that for? I roll. I work in the real world. I don't need theory. Well, we all know from the new change literature, right? You have to have a theory of change rather than just sort of saying, well, I think if we do this, it'll all get better. How? Why? What are people reacting to, right? The only reason that we know that Matching Michigan failed miserably in the NHS is because our team went in and talked at the ground level to everybody involved in it. And we learned it wasn't just the top-down thing. It was the top-down thing piggybacked on top of targets and terror. Okay, so you need to think about how you're going to roll a thing. It's not a one-size-fits-all. A change consultant will come in and say, yeah, you got to get people to buy in, period. Yeah, to this specific intervention at this specific moment in time. And the qual research will help you understand what your moment is and what you're selling to get buy-in.
Thank you, Myles. I have a question, and you started touching on it about this one-size-fits-all solution, and I'm thinking about hospitals that have or any healthcare facility that have their own culture, first of all, and then within a single hospital network, you may have 30 different languages that people speak primarily, and so you've got, in a literal sense, different cultures within the facility. So how much of what you're discovering in your research on people's behaviors and identifying barriers to infection control or solutions to infections, how much of that is generalizable across facilities, and how much of that needs to really be evaluated in a more specific sense?
Great question. Thanks. She's given us a microcosm so that you can really understand. And I think everybody in the room knows this intuitively to be true. People talk about hospitals. People talk, when I was at Hopkins, we had 6 hospitals in our network. These were the Hopkins hospitals. Departments within one of the hospitals were completely different, totally different rules, totally different ways of bending the rules, totally different norms. When you put it in language terms and you start to understand we have 30 different languages represented inside our one institution, wow, this is huge, right? One of the great things about institutions is that they can masquerade as being consistent internally when they are not. It's not just a shell game like at the end of the Scooby-Doo adventure. Haha, it was Old Man Smithers in a land grab the entire time. They're not just good at that kind of stuff. It's helpful. It's good. It gives people a sense of purpose, a thing to go towards. Getting past that and going, okay, the institution does institutional things, but it is massively bifurcated on the inside. trifurcated, quadricated, I don't know how you say that when it's into 1,000 different pieces, is why I'm advocating so strongly for small groups working out their problems locally. It won't be happy naked dancing. Hopefully it's not too much of a mud fight. The only way to get this done is ground up like that. Has to have top-down support. The institution has to engage, but that's the way to get this done, is to acknowledge that we are, in fact, massively siloed, not in an unhelpful way. They do lots of really good work for us. But if we're going to make it better, those silos have to talk to one another at a micro level, across languages, across departments, across, right? Everybody likes the handoffs. That's why I picked that moment from the Dutch study. The handoff between ED to, inpatient. But though any of those places where the silos rub up against one another, that's the really important place for people to be having the micro conversations. Because the macro stuff has gotten us as far as it has, and it's been good. But if you think that the institution is the institution, that you can point at the hospital and say, that's the hospital, we all know in our souls that the hospital is made up of a collection of warring factions who are more or less in sync with one another about anything, right? So let's take that seriously and come up with solutions that allow those factions to come together in a better way.
Okay. We'd like to cut it off right there and continue moving forward, but thank you very much for a great presentation.
Thanks so much for having me.